Well, welcome everyone. Thank you for being here for today's critical care lecture series session. We're joined today by Dr. Ima Chinedozi. She is an assistant professor of anesthesiology and critical care medicine at Johns Hopkins University, where she also serves as an attending physician specializing in cardiac anesthesiology and critical care medicine. With a passion for improving global health, Dr. Chinedozi leads multiple multinational research projects focused on enhancing surgical and anesthesia capacity in low resource settings, particularly addressing issues such as unstable oxygen systems and perioperative education in West Africa. She's also the director of research for the Global Alliance of Perioperative Professionals. Dr. Chinedozi's PICS dedication to evidence-based interventions in perioperative global health is matched by her commitment to education, having mentored trainees at lots of various levels. And she is here to share her expertise with us today as well. So with that said, I'll hand it over to you, Dr. Chinedozi, for your presentation. Thank you so much for being here today.
Awesome. Thank you so much, Amanda. Good afternoon, everyone. How are you all doing? I'm going to go ahead and share my screen, and hopefully it wants to cooperate with me. Are you all able to see my screen clearly?
Looks great.
Yeah.
Yeah, awesome. Beautiful. So how I normally I like to lecture or give a talk is have it as interactive as possible. And so I'm going to actually be calling on people to give answers, or you can volunteer yourself and speak up. But no answer is incorrect. We're all here to learn. And so with that being said, I'm just going to go ahead and begin. And if you have a question, feel free to speak up, raise your hand, or put the question in chat. And yeah, and I mean, just let me know when I'm like getting close to time because I may lose track in all the fun that we're having. Okay, so my topic of discussion this morning or this afternoon for you is evidence for TEE, transesophageal echocardiography in the ICU. My name is Emma Chinedozi. Originally, I am from Nigeria, but I grew up here in the States. I have no disclosures to make. So the things that we're going to talk about are the indications for TEE. Then we're going to discuss contraindications for TEE. It's very important to know that even though we have access to having this really cool piece of equipment, that it is not without risks, and we should be aware of these risks. And our job number one as physicians is to do no harm. And then we're going to focus a majority of our discussion today on the structure and function of the heart. And then we're going to go round up and go through some cases, okay? All righty. So indications for TEE. There are many uses in clinical practice for transesophageal echocardiography. They can be divided into general indications and then specific procedural indications. In the structural heart room, where we put different devices in patient's heart to help either the valve function more or to prevent from clot from forming, we use TEE in those rooms. For cardiac surgery, TEE is at Hopkins almost 100% used for all of our cardiac surgeries. Critical illness or rescue TEE is a fun little topic of discussion that we're going to discuss a little bit more in depth. And as critical care professionals, it will be very imperative for you to know when you can use this modality of imaging. And there are many, many more. It's impossible to give a complete list of all the indications just because of the diversity of diseases and the clinical scenarios where echocardiography can be used. As I lecture and we talk and we discuss, I'll try to give scenarios from my clinical practice of where I've used TEE, both in the operating room, but also in the intensive care unit. Next, we're going to talk about some indications for TEE. But before I do, as I want to keep to my promise of making this talk more interactive, before I show my next slide, can anyone feel free to speak up, think of one indication for use of TEE? I gave some general overviews. Can anyone think of any um, specific case where TEE will be used, will be beneficial?
Maybe in the case of air embolism.
I think someone said something. Can you repeat yourself? Okay.
In case
I'll
of
go.
air embolism.
Oh yeah, I can hear you.
Air embolism.
Oh, air embolism. Okay, thank you. Okay, got it. Air embolism. Perfect. Infective endocarditis. Thank you, Esther. And septic patients. Perfect. Any other indications? These are really good examples. Okay,
Ventricular function assessment.
great. Ventricular function assessment. We're going to discuss that some more. Okay. So this table is provided from the American Society of Echocardiography. They have a very nice, comprehensive and thorough guideline criteria for use of TEE. And this table provides clinical situations where TEE is particularly useful. So it's indicated when evaluating cardiac and aortic structures, especially when it's going to alter patient management. That's going to be key for use of echocardiography in general. Although my topic of discussion is focused on TEE, I will also sprinkle in some TTE in there because some institutions may not have access to TEE. And if you have access to a probe, you can put it on the chest, then there's a lot of similarities. We use TEE when TTE is either non-diagnostic or impractical due to patient factors such as inability to access the chest wall or an inability to visualize the valve for determination of endocarditis, as someone previously mentioned. It is commonly used intraoperatively during open heart surgeries, coronary bypass grafting, and in other non-cardiac surgeries for patients with known or a suspected cardiovascular disease. TEE is often actually not needed in general routine coronary artery bypass grafting procedures. So, for example, in my residency, my anesthesia residency, whenever I delivered anesthesia for for cardiac case, if it was a routine, simple cabbage, coronary artery bypass grafting, we didn't use TEE. A lot of the times we can go on and off bypass without the need of this device. However, if any valves are going to be involved or operated on, then TE can actually help guide the repair of the valve. However, now I'm here at Hopkins and we use TE for just about all of our cases. We also we use TE in emergency cases, such as air embolism. I did have a case where a cardiac case where we initially did not use TEE because it was a routine cabbage, and the patient actually during surgery had an air embolism, we emergently placed a TEE. We saw the air bubbles in the heart, and we had to emergently go on to bypass. So it is quite beneficial. As I said, TE is essential for guiding transcatheter procedures, such as septal defect closures or valve replacements. Additionally, in critically ill patients where you cannot access the chest because they're doing an open belly procedure or there's a thoracic procedure, so you cannot place a transthoracic probe, TE is often a valuable diagnostic tool. So we're going to break it down looking at the first set of indications here, and we're going to discuss some functional reasons. Rule number one, I guess my main rule, my only rule, honestly, is you cannot make a reliable conclusion with inferior images. So if in TTE, you cannot definitively say, if you cannot even see the aortic valve, then you cannot conclude that there is no endocarditis. You have to use a modality where imaging is optimal for you to make this determination. So that makes sense. As I said, if you have a chest wall injury, you also may not be able to use TTEs. TE can be helpful here. And then also other procedures other than the aortic valve, looking at other structures such as the left atrial appendage. Clot often forms there. We use TEE to evaluate the left atrial appendage before proceeding on with other procedures. Okay, so here I'm going, as I promised, I'm going to include some images. So you can see at the top of the screen, the left atrium is labeled, and then the left ventricle is below it. This is a TEE image. And what is this? Before you answer what this thing is, the arrow is pointing to, what cavity is this arrow in? Anybody want to answer? What are we looking at? What is, can you guess? What is this cavity coming off of the left atrium?
Um, is that in the pulmonary cavity and that is the pulmonary artery?
You are very, very close, but try again. So a little thing coming off of the left atrium, a little.
That's the left atrial appendage.
That's correct. That's the correct answer. And so TEE is very helpful for capturing the left atrial appendage. We can even put devices such as a Watchman into the left atrial appendage to prevent from clot from forming in the left atrial appendage. If a patient has atrial fibrillation and where they're increased risk for having clot develop in their left atrial appendage, and they're not able to tolerate anticoagulation for fall risk, any type of bleeding risk, then having a device to kind of occlude that atrial appendage can be very helpful. For us to do this procedure, it just requires sedation. It's a very simple procedure from the anesthesia standpoint, and from the patient standpoint, it's minimally invasive. All righty, next image. So I will give you a hint. I am pointing towards a valve. What valve am I pointing towards? Anyone can answer.
Aortic valve.
Correct. Awesome. That's the aortic valve. So with TEE as opposed to TTE, let me orient you, and we're going to go more in depth later. But if there is a cavity at the top, like a cavity at the top of the screen, that is usually your mid-esophageal view, and that's your left atrium. And so if you know where your left atrium is, and then you know that if you see below it another cavity with a muscular wall, that's most likely your left ventricle. And so the first step is to kind of orient yourself around to make sure that you can identify the cavities. So that's the image on the left is shows the left atrium up top, the left ventricle at the bottom, and then off to the right is the left atrial appendage with the a clot there. Now on the image on the right, you see a little bit of the left atrium at the top. The left ventricle is going to be at the at towards the left here, and aortic valve is kind of what the arrow is pointing to. Now, what is this? Would you describe this thing that's coming off of the aortic valve as? What would you say that is? Anyone can feel free to respond. Does anyone have any idea what this could be coming off of the aortic valve?
There is one contrast matter on the medial thickness of the neutral valve, which could be vegetation.
Think I heard you say vegetation. That's correct. So yes, that this is an example of a vegetation coming off of the aortic valve. One thing that I actually tend to do is before I even start talking about anything, is just describing in words what I see. So you can say echogenic material coming for and then measure it, measuring 1 centimeter by 2 centimeters coming off of the left a coronary cusp of the aortic valve, and that's great. That'll be a perfect beginning. You always want to be cautious before making any determinations, because as clinicians you always want to tie it to the clinical scenario and the case in general. But that's very correct. This would be a vegetation. And then as we mentioned before, there's that's the left atrial appendage, that's the aortic valve. Alrighty. Okay. So I'm a cardiac anesthesiologist. So I use TEE, as I said, for I would say 99% of cardiac surgeries that I provide anesthesia for. At my institution, TEE is used just for about all of our procedures. We also use TEE in other operating rooms occasionally, and also the ICU for patients who have sudden hemodynamic instability. In the non-cardiac OR, the chest wall often isn't accessible. Therefore, TEE is a more reliable option. Um, TEE can also be used in the ICU, but I will be honest, we use it more often in our cardiac ICU compared to our general surgical ICUs, and also in patients who have sudden hemodynamic changes. In our post-cardiac surgery, we are more concerned that, for example, a patient who recently had a coronary artery bypass graft, the graft is malfunctioning for any reason. TEE allows me to tell them which wall is hypokinetic, and that allows me to tell them or to at least estimate which graft that they just put in is no longer functioning. Either way, medication supporting with inotropes or any medications is not going to help. It's a mechanical problem, and which deserves a mechanical solution. So either going to the cath lab or going back to the operating room. I would give an example of more recently. I had a patient when I was coming on the night shift in the ICU who had recently, or maybe a few months ago, had a heart transplant. I was told the patient was stable, no issues, everything is fine. As soon as I started my shift and the day provider went away, the patient became unstable. And so we kept going up and up on our inotropes, and I finally made the decision to take a look at the heart using echo. Eventually, we realized that this patient was going into acute and severe rejection, and we had to crash onto ECMO. extracorporeal oxygenation support. I'm using some terminologies. I want to make sure that we are aware of these terms, and if not, then I can take some time to explain it. Are you all aware, or has anyone heard of the term ECMO?
Yeah.
Okay, perfect. Do you have it at your institution?
Yeah.
No.
No.
Okay, one day. All righty. So for that patient, we had to crash onto ECMO and in the around 2 a.m. All righty. All right. So now I think you guys are all waking up. So more questions are coming. Hopefully. Okay. So um I'll give you a hint. So this chamber at the top is the left atrium. What valve is the arrow pointing to? Anyone feel free to answer. You have 4 choices of valves. You can guess one.
It has to be the mitral, right?
Yes. Okay, great. So perfect. Awesome. So this is the mitral, so this is a mitral valve, but it's a little different from what I'm used to seeing. This is a little, abnormal. Can anyone guess what is different about this valve? Or can you describe, as we're talking about describing, can you describe what you're seeing? It's a little bit hard, but I want you to get practice of just using your words to describe what you're seeing. Anyone want to take a stab at it? Okay. Well, I will help you guys along the way so that you know the terminology to use. But eventually, I do expect for you to start using this terminology because it'll be very helpful as we continue to introduce more topics. Okay. Oh, there's someone in the chat. Acoustic shadow from the exactly. Thank you, Dixon. That's yes, there is some shadowing right here at the annulus. This is a prosthetic valve. And I'm assuming that no one spoke up because they weren't really sure what they were looking at. And it's correct. I don't know what I'm looking at. And so it's good to just use your words to at least say what you're seeing. So you're able to correctly identify that this is the mitral valve. You could just say that there's some shadowing at this mitral valve. There's some artifact at this mitral valve. And the reason is because it's prosthetic. And so the material, the metal and the material, the valve is causing this this shadowing, this hypoechoic shading occurring. Okay. All right. Okay. So other indications for TEE. So medical advances have come quite far. So we don't have to do open heart surgery and go on to bypass for all procedures. Those have a higher complication rate. The recovery is much longer compared to transcatheter procedures. And then some patients are too sick to tolerate the stress of cardiac surgery, and these transcardiac catheter interventions are the only options that they have. As an anesthesiologist, I actually get a little bit concerned when I read about my patient and I read under one of the notes that the patient is too sick to tolerate surgery, and so they're bringing them to me to be able to keep them asleep but alive enough for them to have their procedure. When I was in training, I did have one case where a patient was going to have had severe mitral regurgitation, and they were going to have a transcatheter procedure where they can actually like clip their mitral valve and to help bring it together to decrease the regurgitation. Before we brought this patient into the procedure room before we even had the chance to administer any medication. The patient arrested, and so these patients can be sick, extremely sick at baseline. So just them having, just because they're not having open heart surgery doesn't necessarily mean that it's easier or that they're not sick. So for patients who have stenotic aortic valves or regurgitant valves, an interventional cardiologist can place a device to improve the function of that valve. And we can provide assistance with TEE to guide this process. For aortic valve replacements, actually, transcatheter aortic valve replacements, we don't even use TEE anymore at our institution. And so the science and the perioperative management of these cases is coming quite a bit. And this example, what I'm showing on the screen, is on the right, the picture on the right, it shows you a representation of the left atrial appendage. And as I mentioned before, you can put a device. This is called This is called a Watchman. You can put a device to occlude blood from flowing into this left atrial appendage, slowing down, stopping, forming clot. And so we do these procedures quite often at Hopkins. It's pretty cool. But this is kind of one of the more advanced techniques that a TEE can be used for. All righty. Critically ill patients. So we are all critical care professionals or aspiring critical care professionals. And I mentioned that we're going to talk about, scenarios of sudden hemodynamic changes. And we call this often rescue TEE. So let me see. What is this arrow pointing to? Anyone feel free to answer. Okay, I'll give you a little bit. Okay, let's see. Perfect. Good job, Esther. A pericardial effusion. Yes, that's correct. Okay, so next question, Esther, you feel free to answer, or anyone else can feel free to answer. So what obstructive cardiac emergency is likely occurring, and why? So you said this is a pericardial effusion. So what's going on? What type of obstructive cardiac emergency could possibly be going on here?
So maybe I'm not conversant really with the structures on TEE, but if the effusion is this much, it could cause cardiac tamponade.
Perfect. Awesome. Thank you. Thank you. Thank you for speaking up. And I am purposefully cardiac tamponade. Good job, Edem. Cardiac tamponade. Perfect. Great answer. That is the answer I was looking for. And I am purposefully not talking about the structure or teaching the structure. I'm just trying to assess how much you guys know. And so that will let me know what I need to teach. All right. So yes, pericardial effusion, and you would concerns of tamponade. Now, the reason why this is kind of a trick question, you can't say, definitively that it's tamponade without any other information. So patients could have a chronic pericardial effusion due to cancer of some sort of, volume overload. And as long as their heart is able to compensate, they are going to be relatively asymptomatic. However, what we like to say called tamponade physiology. Basically, they're hypotensive. You see changes to their EKG waveform, then I would be more concerned that this is tamponade physiology and we need to emergently go for a pericardial window. These emergencies are probably one of the scariest emergencies as a cardiac anesthesiologist or an intensivist because depending on what sedation you use, the patient can arrest. And sometimes you can't use any sedation because the endogenous epinephrine and going through their body is what's keeping the patient alive. So even if you use, for example, a benzodiazepine, which should not decrease your SVR, it shouldn't decrease your cardiac output. Just them relaxing can cause them to go can cause them to arrest. And I've been witness to it before. All right, so we'll continue. All right, so now we've talked about the indications for TEE, this wonderful device, but let's also talk about the contraindications. It's very important, as I said, for no harm to be done and to minimize complications. So the absolute contraindications where you want to say no, stop, we shouldn't even be considering this, is if someone has esophageal stricture. If you ask them, a lot of times they have an esophageal stricture, they know, and they'll tell you, oh, I have an esophageal stricture. I often get my esophagus dilated. That type of information is good to ask your patients before when you're consenting them for a TEE. If they have an active GI bleed, if they are admitted to the hospital for a perforated duodenal ulcer, gastric ulcer, esophageal ulcer, if they are vomiting blood and that's why they're there, you probably don't want to place a TEE in their esophagus. Why? Because it can perforate their esophagus. And that's happened before. And so if a patient also has any obstructions, any tumors in their esophagus, you also want to ask that. Other relative contraindications, which should give you reason to pause, is asking is if they've had any recent upper GI surgeries or a history of upper GI surgeries. So if they've had some type of like bypass, gastric sleeve, any type of surgeries to their stomach or to their esophagus, it will make you want to pause. Maybe not put a TE in, but maybe instead of advancing it all the way into the stomach, you just keep it in the esophagus. If there's any varices, if they're coagulopathic, we are always trying to avoid perforating the esophagus because that is a really terrible complication. And oftentimes patients who need a TEE are already sick and we don't want to make them any sicker. Alrighty. And so these are just a list of complications reported with TEE. Diagnostic TEE, I'm assuming, is TEEs done by cardiologists to diagnose certain pathologies. And then intraoperative TEEs are the ones that I do as a cardiac anesthesiologist. And you can see that our overall complication rate is about 0.2%. It's not 0%. But it is, we could do better to improve our complications. All right. So now we're going to start to talk about the structure and function, and I'm going to some of this might be basic for all of you, but if it's basic, then we can shout out the answers quickly, and then we can proceed. Okay. All right, let me see if I can. All right, so there are buttons and knobs on. So this is a transesophageal echo probe. There are buttons and knobs that allow you to maneuver it while it's in the esophagus. You can flex right and left. You can flex forward and backward, and you can omniplane, which basically rotates the slices from 0 to 180. And then on the left shows you the standard 28 TEE views for a comprehensive exam. I will be asking you questions on identifying the structures based off on these images, but we're going to go in depth on these images so that we can all learn together. As you are learning as we're talking about, getting the images, it's not enough to just getting the images and knowing what you're looking at. You also have to interpret what you're looking at. So, okay, yes, you can see the heart, but what is the heart doing? Is the heart not moving? Sometimes when I'm teaching trainees, they are very happy that they've gotten the image, and then they don't realize that the heart is currently failing, and we thought that the ejection fraction was normal. So it's very important to learn how to interpret the images, and the only way you can learn how to interpret the images is by practicing. Honestly, it's just by practicing. And so we're gonna all practice together. All right. Okay, so this is the mid-esophageal view. Some of the mid-esophageal views. As you can see here, on the top is a 5-chamber view, and the bottom is the 4-chamber view. Okay, I'm going to start asking questions. Please feel free to speak up. Okay, so what is this arrow pointing to?
Left atrium.
Correct. Good job. So as soon as you put the probe into the esophagus, into the mouth, go into the esophagus, this is going to be probably one of the first images that you're going to see, that you're going to be able to say, oh, okay, this looks like something familiar. So I would call this home base. This is your left atrium. The chamber that's at the top of the screen is most likely your left atrium. So you correctly identified that. Let's continue to label the other structures. What is this arrow pointing to?
Mitral valve.
Yes, speak up with confidence. The mitral valve, good job. That is the mitral valve. So look at it. Don't just, so you've correctly identified it. Now, since you're such a since you're so advanced, now start looking at it. Okay, this mitral valve looks normal. It looks nice and thin, like it's supposed to be. It looks like it's opening like it's supposed to be. Okay, I don't see, a lot of like bright white. Bright white means that there's like a calcification, there's increased thickening, and increased thickening and calcifications is usually abnormal and is good to report upon. Anything that's black in TEE is most likely blood. If you see like white, that's tissue. If you see like gray and hazy, it could be tissue, it could be blood, it could be like a clot. And so we'll discuss that. All right, so what is this cavity?
Left ventricle.
Correct. All right. I'm moving down to the bottom picture. What is that cavity?
Right ventricle or right atrium? One of the two.
Okay, you have to choose one. Which one is it?
Ventricle.
Right atrium.
Okay, so the answer is right atrium, correct. Is the right atrium. Right atrium. So I purposefully, all the images are not going to be perfect, honestly. Like I rarely see a crisp echo like this. And so it's good to be able to struggle a little bit. We see what it's supposed to look like, but the bottom image is a lot of what we often see. Is not the greatest, but what I like to do is to kind of like focus on what do I do know? Can I identify the left atrium? And then I can figure out what the other structures are, okay? Okay, so we said that top left image is the right atrium. So then what's that?
Tricuspid valve.
Yeah, tricuspid valve.
That's correct, tricuspid valve. Okay, and it might be a little confusing because the arrows are too big. Now, what is this chamber?
Right ventricle.
Ventricle.
Right ventricle. Okay, beautiful. That's not what you're talking about. Okay. And so you guys are now getting used to opening your mouths, practicing, getting the boldness to speak up when you're talking to surgeons. Sometimes they're not completely uncommonly, I tell surgeons what to do, the cardiac surgeons. Sometimes we go in, we want to fix the mitral valve, but then I'm like, hey, this tricuspid valve does not look normal, and it would not be good for you to fix the mitral valve, and the patient is still symptomatic because of severe because of a failing tricuspid valve that was not diagnosed before. Because the images, and why is that? The images that are seen on TEE are much better than the images on TTE. And so sometimes it can be certain pathologies can be missed. And it's a little bit frustrating when you go in thinking that, well, we're just going to work on one valve, and then you're going to, and then, you know, as a cardiac anesthesiologist, we're evaluating and if a patient should have an extra procedure. So now that we're identifying the different chambers, we're correctly identifying the different chambers, different ways that we can assess the function. So again, you always think about two things. First, structure, say what you see. Does this left ventricle look big to me? Does this left ventricle look small to me? Does the wall look thick to me? Does the wall look, very thin to me? What does the function look like? You only learn what is normal by asking someone who is certified, and there's different calculations that you could also do. So these calculations for functional evaluation of the left ventricle and right ventricle, some examples are Simpsons, where we basically take slices of the left ventricle, compare diastole to systole, and the amount of change is your ejection fraction, basically. The different other modalities of evaluation of the function are fractional area change and fractional shortening. Initially, when I was a trainee in cardiac anesthesiology, I did symptoms for all my exams. I did fractional area change for all my exams until I learned what normal looked like, until I learned what abnormal looked like. So now, whenever I'm put on my report, the ejection fraction is 50 to 55%, 30, 35%. I'm not doing symptoms. My eyeball is calibrated, so I know what normal looks like and what abnormal looks like. And to a pretty accurate measure. Feel free to ask any questions if you have any. Okay, so
Yeah.
this is last. Oh, go ahead. Go ahead.
Yeah, is the calculation the same when you're using TTE and TE, for example, if you're doing Simpsons?
Correct, it is. Yes, it is. The frustration because I did cardiac anesthesia first, so I learned how to do Simpsons with TEE. When I changed to TTE, the image just is not as crisp and clear, and so but the calculation is the same. The way of obtaining it is the same. Great question. And a lot of the numbers of what's normal and abnormal has been validated on TTE, so that's important to know. It's been validated on TTE.
Okay.
Now this last arrow, let me make it pop back up. This last arrow, what is that last arrow pointing to?
The article.
Correct. So this probe, in summary, this probe, we just correct Tobias. We just placed a probe into the esophagus, and we're getting this image. We have not omniplaned it. We have not anti-flex, retroflex. We haven't turned it to the right or to the left. We just place it into the esophagus. This is the first image that we see. If you advance a little bit more, you see this bottom image. So the top image says it's the mid-esophageal 5-chamber view, and then the bottom one is a mid-esophageal 4-chamber view. So what's the difference? Anybody feel free to shout out what you're thinking. How is the 5-chamber view different from the 4-chamber view? Is different by one thing, and you guys had already answered it.
You can see the aorta on the 5-chamber
Yes.
view.
So it's not a chamber, but yes, you can see the aortic, the LVOT, and the aortic valve. So that's the 5th chamber. And so it's just a little bit higher up. So to get from, let's say, the top image to the bottom image, you just advance your probe just a little bit in a perfect situation. Sometimes the heart is not in the chest cavity perfectly, and so we got to do some maneuvering. But in a perfect situation, you just advance a little bit further. These are very interchangeable. Okay. So since you guys are so smart, I'm gonna go a little bit faster. Okay, so this arrow is pointing to something. I'm gonna give you guys some time to think about what this could possibly be, and it's gonna be really hard. I'm sorry. Maybe you can use some Google to help you. So these next two images are the mid-esophageal mitral commissural view and the two-chamber view. So why they look the same to me, honestly. When I was looking at this looks very similar, especially on TEE, they look very similar. But if you can look here, there's like a little scale right here. The top view is omniplane, basically the slice, the echo slice is at around 60 degrees, and the bottom view, the slice is rotated to around 90 degrees. And so why is this important? It's nomenclature, so that without me seeing what you're seeing, if you say I'm at the mid-esophageal commissural view, I know exactly what you're looking at. And so it's how we talk to each other as experts. So it talked about how to get to this view. So you've gotten to your four-chamber view. You put your probe into your esophagus, and you have to turn your knob to about 60 degrees. 60 degrees gets you the top image. Omniplaning it to 90 degrees gets you your bottom image. You can interrogate the mitral valve. You can see if there's any regurgitation. You can say exactly what leaflet is not functioning. From these views, you can also assess the function of the left ventricle, and you can also assess the size of the left ventricle and the left atrium in these views. Okay, now back to my question. I haven't forgotten. What is this arrow pointing to?
Is that part of the aorta?
Oh, you're almost there.
Coronary artery.
It's the coronary sinus. I wouldn't have gotten this if I was in your shoes. So coronary sinus.
Oh.
Yeah. Alrighty. So I'm going to go a little bit faster if that's okay. Now to get from the previous image, so remember, this is our home base, our four-chamber view. Now to get to this view, all you do, you don't move your probe, you just press a button and you omniplane it to 120 degrees. That gets you both of these images. The difference between the top image and the bottom image is zoom. So the top image, you're just looking at the whole thing, the left ventricle, the aorta, all the things. The bottom image is focused on the aortic valve, and it allows you to take more precise measurements, okay? So the top image is called the mid-esophageal long axis view, long axis of the aortic valve. And the bottom image is basically mid-esophageal aortic valve, long axis view. It's basically the same thing. All right. Let me see. Do I have any questions here? Okay. So the top of the screen is the left atrium. The top is the left atrium, then the left ventricle going out into your aorta. Is this chamber then that this arrow is pointing to? I gave you a hint. It's a chamber. So you only have two choices because left atrium, left ventricle are already taken. Anyone can guess. Okay,
Right
let's see.
ventricle.
Yes, good job, Tobias. Good job, whoever said what you said. Yes, it's the right ventricle. Correct. Great. How I make the determination before I knew. This is not the best image because it's not live. But the wall is a little bit thicker than an atrium, and so that's kind of like what helps me to determine like what chamber it is. Okay, so that's the top image. The bottom image is zoomed in a little bit more, focusing on the aortic valve. And now I'm going to label the different parts of the aortic valve that we like to measure. And this from the LVOT up into the ascending, this whole thing is called the aortic root. But a lot of the times people, when they say root, they mean one specific thing. So let's go to naming it, and then we can discuss a little bit more. All right, so that's the LV. All right, so this is the ascending aorta, the proximal ascending aorta. This right here is the sinotubular junction. Sinotubular junction. The names make sense. And so because this is the sinuses of Valsalva, this is the tube. So sinotubular junction. So now you'll never forget that. That is the sinus of Valsalva. And then the annulus, the aortic valve annulus, is just right below it. All right. Now this is more of this is still mid-esophageal, but it's a little bit higher. So if we go back to our home base where we see the 4 chambers, if you remove your echo probe just a little bit, you'll get to this view. And this is basically an image of your PA branching into your right and left pulmonary arteries, and then your ascending aorta. Sometimes if a patient has a clot, you can actually see the clot in transit. If they're having a PE, an embolism, you can see the clot in transit. This is the view that you would go to see the clot. All righty. All right. So running short on time, so I'm just going to describe the images, and then I'll ask just a few questions. All right, so this is a mid-esophageal short axis of the aortic valve. This is basically crossing it, cutting in a cross section. Short axis of the aortic valve. And the RV inflow, it basically just focuses on the RV. They're basically the same image. All right. So let's talk about the coronary cusps. So this is the aortic valve in the middle. The aortic valve, as you can see, has 3 cusps. Okay. What is it, before I continue, what is this arrow pointing to? Anyone can guess? It's a chamber. Beautiful. Left atrium. Left atrium. Correct. All right. So this is their aortic valve. Now, the aortic valve is divided into coronary cusps. There are 3 of them in normal patients. There could be bicuspid, there could be quadricuspid, there could be unicuspid. Those are all very bicuspid is not that, uncommon. It's still rare, but it's you'll see a few of them if you're looking. But unicuspid and quadricuspid are very rare. All right. So how do you make the determination? The reason why I like TEE is because things just kind of like make sense. You can see it clearly, and once you kind of like know how to identify things quickly, you can kind of figure out the rest. All right. So you said that this top chamber is your left atrium. Okay. Now this right here is another atrium. Okay, what atrium is this? There's only one more, right? This is the right atrium. So this is the left atrium up top to the screen, like bottom and like left. That's the right atrium. So then what is this chamber at the bottom? Anybody feel free to answer.
Right ventricle.
Yes, good job. Correct. Right ventricle. So that's the right atrium. And so then what is this? This is the tricuspid valve, and that is the right ventricle. And you may not be able to see this, but I have one more arrow. So we have the left atrium, the right atrium, the tricuspid valve, the right ventricle. So then what is this next arrow pointing to? You can't really actually even see it, but there's a valve there. What valve is the arrow pointing to?
Mitral valve.
You say mitral valve?
Yeah.
Try again.
Tricuspid. Has to be tricuspid.
Try
Aortic valve.
again.
Sorry.
Try again. There's only one more left. Pulmonic valve. Good job, Dixon. Pulmonic valve. And so now you'll never, because you see it's right there, the pulmonic valve. So the tricuspid valve, the aortic valve is looking at you right in the face, staring at you. You have the tricuspid valve. The mitral valve is not in view, but here is the pulmonic valve going into the PA. Okay. Now the aortic valve, as I said, has 3 cusps. The one on the top left top left of the screen, that is your non-coronary cusp. The one on your bottom is your right coronary cusp. It's closest to the right atrium. And the one on the right hand side of the screen is your left coronary cusp. So how I memorize it, or like, orient myself, I find where the intraatrial septum is, and I know that's the non-coronary. Then I go to the right ventricle, so that's the right ventricle, so then that's the right coronary, and then whatever is left over is the left coronary. Does that make sense to you guys? Makes sense to me. All right, so now the mid-esophageal bicaval view. So this is omniplaning to around 110, and then you have to rotate the probe and you get this view. Okay, so this is the mid-esophageal bicaval view, bicaval. So the names kind of help to explain the structures, okay? So if you know the mid-esophageal bicaval view, what is this arrow pointing to?
Right atrium?
Left atrium. That's what I heard you say. Left atrium. Yes. The chamber at the top of the screen, if it's black, is most likely left atrium if you are in the mid-esophageal view. So that's the left atrium. So that's the left atrium. If that's the left atrium, and this is the interatrial septum, I'll give you that as a hint. This is the interatrial septum. What is this? What chamber's at the bottom?
Right atrium?
Correct. All right. So that's very correct. So now this is the bicaval view. So these are vena cava. So which vena cava is this? You can just guess.
Inferior.
I think you said the superior vena cava, and that's correct. It's the superior vena cava. And so then this is, it's kind of like going up. This is the inferior vena cava. If you are putting a central line in and using your wires, this view can see you where your wires to make sure that it's going in the right direction, that you're putting your central lines in the right direction. You can put some color on this, and you can see if a patient has a PFO. This is what cardiologists do to assess if a patient has a PFO. So this is a very handy view. It's a very easy view to get to. All right. All right, I'm gonna have to wrap it up, but I think this is very important. So I'm just gonna go through this really quickly, if that's okay. So this is the stomach views. So these are the transgastric views, stomach views. So how you get to this is you have your home base, your 4-chamber view, where you can see all of your atria and ventricles in a beautiful orientation that looks nice and normal. And you're gonna advance it into the stomach. The first image that you'll see is the basal view, the transgastric basal view, the base of the LV, and you can see where it's cutting. Your omniplane is 0 degrees, as shown here, is the base of the LV, and you can see the mitral valve here. And you basically see the the LV in short axis. Okay, the middle. Does someone have a question?
Is this the same as the short axis view on the TTE?
Mm-hmm.
Okay.
So yes, you're going back and forth. So the only difference between TTE and TE, sometimes the images are like upside down. And so in TE, what is anterior is inferior, and what's inferior is anterior. So that's just the only thing to keep straight in your mind. But having the experience is very helpful in helping you to identify the structure. So this is your heart. In short axis. This view in the middle is my money view. This is the money shot. This is the view that I like. So this is the mid-papillary short axis view. Why do I like it? Because I can do so many things. I can tell so many things by looking at this view. I'm going to go into it a little bit later. This view is, so how you get from the basal view to the mid-papillary view is just you advance it a little bit more. How do you get from the mid-papillary view to the apical view is just advance a little bit more. You don't omniplane, you don't twist and turn, you just advance. So this is the first view, second, and then third. This allows you to measure different cuts of the heart. You can assess your valve in the topmost image. But the middle image, but all the images, but the middle image is my money shot. I can assess your function, the function of your heart, globally. So what is the ejection fraction? You don't do Simpsons with this image. You can do fractional area change and fractional shortening. You can just look at it generally and you can say, oh, that looks pretty good to me. That looks pretty normal. Oh, that's not moving at all. So you can look at the function globally. You can look at each wall. So you can look at the inferior wall, which is this topmost wall. You can look at the lateral wall, which is this one on the right. You can look at your anterior wall, which is the one at the bottom. And you can look at the this wall, which is your septal wall, which is the one that is right next to the right ventricle. Just remember, this is TEE. This is in the esophagus. The probe is in the esophagus, so you're looking at the heart from inferior, from behind. So this topmost portion is going to be the most inferior wall, and then the one that's furthest away from it is going to be anterior. Is the anterior wall. It's the opposite for TTE. So we can look at, as I said, global function. You can look at regional wall motion changes. So there have been times where I saw that one of these walls was not functioning, and I was concerned that one of the coronary grafts had gone down, and we went and fixed it because I was correct. You can see the thickness of this left ventricle. If the left ventricle, if you measure it real quick, and it's greater than 1.1 centimeters, then that's a hypertrophic ventricle, and you would be concerned about there's it will lead you to have other questions in your brain that pop up. And you can look to see how big is the ventricle. Is it opening and closing normally? Does it need more volume? Do you need vasopressor? So this is, I like to call it the money shot because it tells me a lot of information in one image. And I don't just look at this image, I look at the function at the apex and I look at the function at the base because it could change. So you can say, your anterior septal wall is your mid anterior septal wall is hypokinetic. It tells me and whoever is reading your note exactly what wall, where it's at, and what the function is. Okay. All right. And then this is just another image. It's gonna be a little bit challenging, but sometimes this is what you got. But this is looking at the aortic valve. This is basically advancing the probe all the way kind of like deeper into the stomach, and it's called a deep transgastric view. This is the view if you want to assess the function of your aortic valve. If it's regurgitant, if it's stenotic, you obtain this view. And then the bottom image is your two-chamber view of your transgastric two-chamber view. It allows you to also look at the function of your heart, and you can do a few other. You can look at the function of your heart. You can omniplane this a little bit more and get the actually aortic valve to pop into place. But these are pretty useful images. All right. So we won't have time to go in depth into or to go talk too much about the valves, but as we have identified the structure and structural abnormalities of your ventricles, you could also do the same thing for your valves. We didn't talk too much in depth about the numbers that we can obtain to quantify what we're seeing, but there are numbers, just know that. So we have 4 valves. You have on the left is your aortic valve, which your cusp label that we talked about, your non-coronary, your left and your right. You have your mitral valve, which are anterior and posterior mitral valve. And you can see the leaflets you can see like clefts there. So it kind of helps you to realize that for your mitral valve, each leaflet is actually kind of divided into 3. You can see here P1, P2, P3. And there's also an A1, A2, A3, and that allows, determination of which specific leaflet, which area of the leaflet is malfunctioning, because there could be clefts, there could be holes, there could be perforations, there can be vegetations. You don't just say there's a vegetation on the mitral valve. You say on the P2 leaflet, there is a 1.1 centimeter vegetation. It allows you to be very specific with describing with what you're seeing. Here is an image of your tricuspid valve is on the rightmost. So you have your septal leaflet, your posterior, and your anterior. And then there's no real good image of your pulmonary valve, but there it is. in addition to just looking at the image, you can use color. So color Doppler, it allows you to see pretty colors, but it can show you if a valve is leaky or regurgitant or insufficient. These kind of all are synonymous. So leaky, regurgitation, insufficiency, they mean that your valve is incompetent for one reason or another and is allowing blood to flow in a direction that it's not supposed to. You can, when you interrogate your valve, in addition to just looking to see how blood is flowing back and forth, you can also assess the velocity of blood flowing across that valve. If that valve has a very high velocity, then you conclude that the valve is stenotic, is very narrow. It may even need to be replaced. But this continuous wave Doppler allows me to do those calculations, to give me numbers. So when I say this aortic valve is has severe aortic valve stenosis, I can give you a number. And so so we can talk about imaging modes. What all these images that we're seeing, I've shown you, are all 2D images. They're all 2D. There's also, and we just talked about color Doppler and continuous wave Doppler. And there's also M mode, which stands for motion mode. I know this is a lot of information, but I want you to at least hear of it. And so then you can always go back and refer. So when someone else teaches it again, it'll somehow sound a little bit familiar. M mode, which stands for motion mode, it basically allows you to measure the distance. So it's basically one-dimensional. It allows you to measure the distance. So you can calculate your fractional shortening. You can calculate how big your ventricles are by using M mode, going through going through your ventricle, your atria. So it allows you to be able to measure things. And then Doppler in general, because it's a little confusing. You have your probe, and there are crystals at the end of the Doppler. There's two general types of Doppler. There are other Dopplers, but there's two Doppler modalities we're going to talk about. One is pulse wave Doppler. The other is continuous wave Doppler. So for pulse wave Doppler, you can see here on the screen, you're sending a pulse, and then you're waiting for it to bounce off of the whatever object, the ventricle, the valve, and then it comes back to you, and the probe analyzes it. So it waits for the pulse to come back, and it reads it. So yeah. So it sends and it receives. It sends and it receives, but it doesn't do it at the same time. Continuous wave is continuously sending and continuously receiving. And so it sends and analyzes continuously. It's a big difference. And so so for pulse wave Doppler, because it can't send and receive and analyze at the same time, it's limited on like how much information it can process. So that's why the image looks like this. Isn't it's not shaded in. All right. This is basically pulse wave Doppler going through the mitral valve. I'm able to do calculations to say, this mitral valve doesn't look like it's normal. It looks like it may be a little bit narrow. It may look like it may be a little bit tight or maybe a little bit regurgitant. This is what pulse wave Doppler is good to give us quantitative values for. Continuous waves Doppler, because it's sending and receiving, it allows us to monitor higher velocities. And then this is just another image of a color Doppler going through a valve. And I was hoping that we would have time to bring it all together. But let's just go through one case, okay? And then that'll be it, I promise. Okay, so a 75-year-old female, history of hypertension, hyperlipidemia, COPD, atrial fibrillation on no anticoagulation because of a previous bleed. Has sustained multiple rib fractures after a motor vehicle accident. She has gotten rib plating. However, she was unable to be weaned from the vent. She has bad COPD, couldn't be weaned from the vent. Comes to the ICU ventilated. The next day, a couple days later, these are her vital signs. So she's tachycardic, heart rate 110, Blood pressure is a little hypotensive, 88/57. And she's hypoxic too. Pulse ox 87%. The decision is made to obtain a TEE because well, an echo and a TEE in particular because of her rib plating. We can't get access to the chest, and she's ventilated, so we're going to put a TEE in. This is the image that you see. So you see the RV, you see the LV. Okay. So, can anybody tell me what view this is? Is this in the esophagus or is this in the stomach?
Stomach.
Yes, correct. It's in the stomach. And so this is your left ventricle. I've already identified that to you. This is your right ventricle. Right ventricle is looking a little bit big. That's your hint, okay? So can you describe what you're seeing? Anybody feel free. There's no wrong answer.
The right ventricle looks bigger, and the left, I don't know exactly where the LV is visualized, but if it is the middle, then that's definitely smaller related to the RV.
Correct. So the LV is smaller than the RV. So is that, and we know that's not normal. The LV is normally is a bigger ventricle. It should be normally bigger than the RV. So what additional studies? What are your differentials? Knowing this, knowing that this patient recently had surgery, is now hypoxic, hypotensive, tachycardic, enlarged RV. And this is the interventricular septum. And as you can see, it's supposed to be like round because the LV has higher pressures. It's supposed to be like round, but it looks like a D, right? A D. It's called a D sign. So what are you concerned about?
PTE.
Yeah, PE. Yes. Yeah. So this has happened before to me. What would you do? What would you guys do if you're in the ICU and you see this?
D-dimer or CT angio, whichever.
Yes.
Yeah.
What else?
Chest CT.
You would so you get all the diagnostics. You can even look to you because you have an echo. You can look into yes.
Yes,
So
device.
yes, treatments. Yes, treats. So yes, you could you can do D-dimer. You can do would not wait for a C. I think with all of this constellation of symptoms, I would have a very high, predictive value that this is a PE. And I would not want to, I would say waste time, depending on like how stable she is, or getting a CT angio. You also have the TE. Remember, you can look at your pulmonary artery, see if you see clot. If you see clot, then hey, get rid of the clot. So you can do thrombolysis. If you guys have the capacity to get the capabilities, you can go get a thrombectomy. You can start heparin. Heparin will not destroy the clot. It's not going to bust up the clot, but it will help prevent new clot from forming. And then you can give TPA. So that is my presentation. Most of my source was American Society of Echocardiography. If you want extra like instruction, PTE masters is what I would say like 99% of us cardiac anesthesiologists use to basically teach us echo. I wish I would have had this presentation when I was a fellow. I'm putting my contact information because I forgot to show that slide. If you do want to get a hold of me, I'm putting my contact information. And sorry, I probably took up all the time for like questions and Q&A, but that's all I have.